Hi everyone, welcome to this presentation titled Pregnancy, Anticoagulants and Anesthesia, a trio of care. My name is Nazuha. I am an obstetric anesthesiologist at Hospital Tanah. Before we start, I would like to express my heartfelt appreciation to the Malaysian Obstetric Medicine Society for inviting me to share this presentation. Um, their efforts to promote education and collaboration in maternal care inspire continuous improvement in the field. So today I will try my best to guide you through the role of anticoagulation during pregnancy and its implication for anesthesia. So let's dive in. In this presentation, we'll focus on four key learning objectives. First is to understand the indications for anticoagulation during pregnancy, identify the common anticoagulants prescribed antenatally, and briefly look into their pharmacology properties, discussing the anesthesia implication, especially related to usage of neuraxial technique, spinal or epidural anesthesia, which is the most common mode of anesthesia in pregnant patients. And lastly, we will look into the strategies for safe management of anticoagulated obstetric patients. By the end of this talk, I hope that I may be able to give some insights on how to improve and collaborate with your anesthesia team to improve patient care and outcomes. Venous thromboembolism, or VTE, is a major concern in pregnancy. It is responsible for 10 to 14% of maternal death in countries like the USA and the UK. During pregnancy, the risk of VTE increases fivefold due to physiological and immunomodulatory changes, and this risk skyrockets 20 times in the postpartum period. The overall prevalence is around 2 in 1,000 deliveries, with most cases involving venous thrombosis. Women with a history of VTE faces a 10% recurrent risk in subsequent pregnancies if left untreated. So this diagram summarizes really well on the four factors that contribute to the pathophysiology of venous thromboembolism in pregnancy. Uh, the condition, the presence of hypercoagulability state, hemodynamic changes, immunomodulatory changes, and also venous stasis. All this leads to a much higher risk of getting venous thromboembolism during pregnancy. So let's look into the Malaysia situation. So in the recent 2023, five of the most common cause of death among pregnant women in Malaysia, then obstetric embolism contribute to second most common causes of maternal death. However, I couldn't really find the because obstetric embolism here could also include amniotic fluid embolism, but I do think that majority of this obstetric embolism in this case would be venous thrombosis. I think the details of maternal death, the latest update would be for the year of 2015 until 2017, and we can see here that in this triennial report, obstetric embolism is the leading cause of maternal death. It is actually compared to the year of 2012 until 2014. It was, I think it was the second most uh, the contributory of maternal death compared to the latest one, the latest analysis which were done in 2015 until 2017. So I think the upcoming 3 years analysis will be updated soon. So we are going to see what is the latest analysis, whether the obstetric embolism still is the contributory cause of maternal death. Now let's discuss who actually needs anticoagulation during pregnancy. The key indications would be a history of VTE in prior pregnancy or even if she was not pregnant, if she had a previous venous thrombosis history, um, patient who had thrombophilia, such as patient who had homozygous factor 5 laden, protein S and C deficiencies, and or patient who had recurrent pregnancy loss. There are a group of patients who actually already have been anticoagulated lifelong due to presence of valvular heart disease and atrial fibrillations. So when they get pregnant, still have to continue their anticoagulant to prevent valve thrombosis or any other thromboembolic complications. And I think it is not a surprise nowadays where, I mean, in talking about my experience, my first patient on the list of my cesarean section list could have all the risk factor mentions in number 3. They're coming for cesarean delivery for obstetric indications, for example, multiple gestation. They are also obese. They are at advanced maternal age, and they are having preeclampsia as well. So you can see that for one patient, they could already have more than 3 morbidities that actually put them at risk of venous thrombosis. So, anticoagulant prescribed to parturients have critical significance for anesthetists because um, although this is beneficial in the long run, um, because we preferred and it is proven that neuraxial anesthesia is much more safer compared to general anesthesia, we would like we would prefer for this anticoagulant to be withhold prior to um, uh, patient going for labor or coming for cesarean delivery. The concern about risk of neuraxial hematoma is actually quite real. Although after this we will look into a few analyses that look into how frequent is the incidence of neuraxial hematoma among obstetric patients. And I think the most important thing is the key to understand the effect of the implication for anesthetic care is actually to understand the pharmacology of the drug itself. So, what is the most common anticoagulant used antenatally? So, I think most of you are probably much well versed than me when it comes to the pharmacology of anticoagulants that being used antenatally. So I can see that in our practice, unfractionated heparin and low molecular weight heparins are most common being used, and I think low molecular weight heparin is much more being the preference. It does not cross the placenta, and it has a good safety profile during pregnancy. And low molecular weight heparin is generally preferred because of the predictability and it's reliable. It do not need to be dosed as frequently as unfractionated heparin. And the incidence of heparin-induced thrombocytopenia is much lower. The American College of Obstetrician and Gynecologists and Royal College of Obstetrician and Gynecologists has recommended a different approach in starting patient on prophylactic uh, anticoagulant. Uh, for ACOG, they actually recommend a fixed dosing, while the RCOAG recommendations are weight adjusted. For the therapeutic low molecular heparins, they are dosed twice daily based on maternal weight. Warfarin is a vitamin K antagonist less frequently used during pregnancy given its teratogenicity and ability to cross the placenta. However, warfarin is much more superior to low molecular weight heparin for the prevention of mechanical heart valve thrombosis and may be selected for certain patients with mechanical heart valve after the first trimester, for whom adequate anticoagulation is critical for safety. DOACs, we like to call them DOACs, the direct oral anticoagulants, which is nowadays is becoming one of the quite common anticoagulant being prescribed in non-obstetric populations. However, the safety profile for dog in pregnancy is not well established. They are typically avoided during pregnancy given insufficient pharmacological data and the inability to exclude the risk of harmful effects on the fetus. And this drug can transfer into breast milk, and as a result, their use is very much discouraged during breastfeeding. Bacterians are increasingly being treated with low-dose aspirin for prevention of preeclampsia. So women at risk are recommended to take between 75 and 150 milligram of aspirin daily. Any of the following high-risk conditions are considered for aspirin prophylaxis. So what are our strategies? What are the impact of having this anticoagulant being started and is antenatally? So the risk of uh, vertebral hematoma with neuraxial block is something that we are really worried about because we 99% of the time we encourage the usage of neuraxial analgesia, spinal or epidural anesthesia, because it has provide a safe and effective pain relief during labor, and it is the preferred form of anesthesia during cesarean delivery. However, complicating the provision of neuraxial anesthesia in patients receiving anticoagulation therapy is the risk of neuraxial hematoma. Although the risk is difficult to quantitate given its rarity, the reported frequency in obstetric patients also varies widely. So a 5-year multicenter US dataset with self-selected cohort found the risk of epidural hematoma to be in 1 in 250,000. Um, a retrospective survey of all 85 Swedish anesthesia department assessing all neuraxial complications found that there are 2 obstetric-related spinal hematomas, both in patients with HELP syndrome. So the estimated risk of spinal head hematoma was found to be 1 in 200,000 patients, which is not really that far off from the number that from the multi-center studies in the US. And let's look into another large analysis. There are 80,000 obstetric epidural blocks in this multi-center perioperative outcome group audit, and they also found that there is no cases of epidural hematoma. And back in, I think it was in 2008, the Royal College of Anaesthetists actually performed a national audit project to actually look into complications of neuraxial blocks. And in the obstetric population, there are about 300,000 plus numbers of neuraxial block being performed, and they found that there is no reported spinal hematomas at all. So another interesting study in 2017, systematic review of 296 obstetric patients receiving thromboprophylaxis with either unfractionated heparin or low molecular weight heparin. And in this study, they found that there were also no cases of spinal epidural hematoma. And interesting enough is that 296 of these patients, 80 of them, thromboprophylaxis were actually continued during labor and epidural. And there were even a number of patients that even at a recommended time interval, the time interval was not even fulfilled yet, and they were given neuraxial procedure. In this group of patients, there were no incidents of spinal or epidural hematoma being recorded, which is very interesting. But still, in non-obstetric population, the incidence of spinal epidural hematoma is still significant, and there is an understandable hesitancy among anesthetists to actually perform this, even more so in obstetric populations. So Previously, American Society of Regional Anesthesia, and so does the European Group and Association of Anesthetists, which is a group from UK, they come up with a guideline on how to a guide on the interval of time allowed for spinal or epidural can be used for anesthesia or analgesia. But bear in mind that most of these guidelines is meant for non-obstetric population. So Society of Obstetric Anesthesia and Perinatology came out in 2018 a consensus. They don't even call it guidelines, they call it a consensus because there is absolutely no randomized control trial that can guide us in understanding the pharmacology and pharmacodynamic, because pharmacodynamic and pharmacokinetic of anticoagulation in pregnant patient is absolutely different from a non-obstetric population. So whether those guidelines can be applied to obstetric population still remain debatable. So the SOAP guideline tried to come out. They actually use almost similar to the one that has been advocated in the ASTRA group. It's themselves, but there are a few additional guides that can help us, especially anesthetists, in deciding whether embarking on neuroaxial anesthesia it will be more beneficial to the patients. However, I just want to attract you to the point here that when aspirin alone being used for preeclampsia prophylaxis, it is not we can perform spinal or epidural anesthesia without any contraindication, without any limitation. But bear in mind that if the aspirin is being combined with for example Clexane or for Parinox, this will lead to um, the, the guideline saying that you have to like wait for 12 hours before you give patients spinal anesthesia. It may not be applicable because aspirin and anticoagulant may have some synergistic effect, and if the interval is not well documented, we may put patient at risk of spinal epidural hematoma. So we have to keep that in mind as well. All right, due to the rarity of the occurrence of spinal epidural hematoma among pregnant patients, we very much depends on case reports to actually try to recognize factors that actually contribute to spinal of epidural hematoma in pregnant patients. It was quite unlucky that women that has shorter than recommended time interval and emergent situation may not be able to receive spinal or epidural anesthesia. In the high-low study, this study actually interesting is that of course it tried to compare the weight adjusted intermediate dose low molecular weight heparin with fixed dose low molecular weight heparin. But one of the interesting analyses that come out of this study is that 460 of the patients enrolled in this study do have an unplanned onset of labor. So quite a high number of them weren't able to receive neuraxial analgesia or anesthesia. So 90% of 31% of these patients probably did not have could not receive any epidural or spinal anesthesia. So such limitations must be recognized, anticipated, and we have to discuss with the patient that if the time elapsed is insufficient, they may have to undergo cesarean section with general anesthesia. So a multidisciplinary consideration should be discussed with our obstetric colleague, whether to see whether a scheduled planned induction or allowing a patient to go into spontaneous labor would be more beneficial to the patient. The problem with the use of low molecular weight heparin closer to the time of delivery include its long half-life if you compare to unfractionated heparin. And there is also the lack of any standard reversal agents, because although protamine can um, reverse half of the low molecular weight heparin activity, it is still not going to be able to safely provide you uh, whether you still can perform a spinal or epidural even after you have reversed the patient. So one of the suggested uh, plan is to transition to unfractionated heparin from low molecular weight heparin, especially if a patient had a very high risk of um, anesthesia or high risk of surgical delivery. For patients such as patients who had mechanical heart valve, this is more challenging because their therapeutic anticoagulation need to be continued during the peripartum period. Heparin often need to be discontinued 4 to 6 hours before projected delivery, which is very difficult to predict, and epidits monitored regularly. Neuraxial anesthesia may be an option, but the laboratory studies must be within normal range and anticoagulation timing guidelines have been met. Protamine is not um, uh, encouraged to be used to allow patient to go for spinal or epidural analgesia, but it is being suggested to be used if the patient had an expedited delivery, postpartum hemorrhage, or both. So for postpartum anticoagulant, ACOG recommend the anticoagulant therapy to be started no sooner than 4 to 6 hours after vaginal delivery and no sooner than 6 to 12 hours after cesarean delivery. Timing of the last neuraxial anesthetic must also be taken into account, and I think as anesthetists, I think we need to communicate this to our obstetric colleague, especially when um, the attempt of spinal and epidural was multiple time. It was a traumatic, difficult epidural or spinal. It was we were having complication like bloody tap. This must be conveyed to the obstetric team so that the timing of caesarean, the timing of restarting anticoagulation can be safely considered. So these are the recommendation when to start, when to remove catheter removal, when to restart back anticoagulant. So I think it was quite easy for unfractionated heparin, but for Clexane, uh, whether low dose or high dose, you need to wait for a longer time. So what is the role of anesthesia, consultation, early referral, and planning? So for anesthetists, this is an opportunity to ensure that the patient has a plan for bridging or stopping their anticoagulant medication before delivery. And this is also an opportunity to educate women the implications of their anticoagulant medication and the timing of a neuraxial procedures. Um, the use of unfractionated heparin nearing term may provide the highest flexibility for management of anesthesia. Although, yeah, patient may presented less than 4 hours after stopping heparin, but it is a much attractive option compared to low molecular weight heparin. So via a multidisciplinary discussion, patients who are particularly high risk of difficult airway, high risk of operative delivery or preterm delivery may be a candidates for such a bridging technique. I think it is also important not only to focus that, or okay, so you are not gonna receive any neuraxial block, you're not gonna be able to receive epidural, you're not gonna be able to receive any spinal anesthesia. I think it is also important to discuss the potential alternative, such as PCA fentanyl, PCA remifentanil, and it is necessary to advise patients that they may need a general anesthesia because of the inappropriate amount of time having elapsed since their last dose. Shared decision making and thorough consent process in a situation is very, very important because the impact of difficult airway is very real. And can you imagine when you have a patient with BMI of 48, She just had some meal 2 hours ago, a heavy meal, and her last dose of low molecular weight heparin was only 4 hours ago, and the time elapsed was supposed to be more than 12 hours, right? So this is the dilemma that we have to face. Just wanted to give you a perspective of the difficult obstetric airway. Even 40 years into for the past 20 years, 40 years, the incidence of failed and difficult obstetric intubation remain the same. It remain higher than in non-obstetric populations. Okay, so it's very real, right? And it can have a devastating effect to the mother and also to the fetus. So these are our anesthesia concern. So we are concerned about risk of spinal epidural hematoma, but at the same time we are also concerned about the risk of general anesthesia towards moms and babies. So risk and benefit, proper planning, and also having two anesthetists handling the airway would be the best plan in case that if patient cannot have any spinal or epidural anesthesia or analgesia. So the Society for Obstetric Anesthesia and Perinatology, their consensus statement not only advise on the time interval prior to neuraxial anesthesia, they also advise on the thought flow on how to actually approach patient with anticoagulant. So it consists of the dose that has been given to the patient, how much she is being receiving. And after you've known the dose, we look into the how much time elapsed since the last dose. And if coagulation status is available, what is the status of the coagulation status result? And after going through this thought process, then we will think about whether it is likely low risk to proceed with neuraxial anesthesia, which is including labor epidural, spinal anesthesia, or consider not proceeding with neuraxial because the inability of the presence of high dose um, less than 24 hours since the last dose, and there is no coagulation status to guide on the risk of spinal epidural hematoma, it may be wise not to proceed with neuraxial anesthesia and to have a plan for general anesthesia. Same thought process goes for low molecular weight heparin. We have to go through what is the dose that the patient has been prescribed, when is her last dose that she has been taken, and if it fulfill the time elapsed, it is likely low risk to proceed with neuraxial anesthesia. And even if we do consider not to proceed, we also have to balance potential increased risk for subdural for spinal epidural hematoma with risk of general anesthesia, and this is the most I think difficult part to actually go through. So in summary, anticoagulation in pregnancy demands a multidisciplinary approach to balance maternal safety and anesthetic efficacy. So I think with a proper planning, adherence to guidelines, and strong communication and cooperation, I think we can achieve the best outcome for both mother and baby. I hope that by the end of this talk, you may have some clarifications on how to actually safely provide anticoagulant, and how to actually communicate this concern to your anesthetic colleague. And I hope that I have shed some lights on how to approach on pregnant patient with anticoagulant prophylaxis. And with that, I thank so much. I thank you, the Malaysian Obstetric Medicine Society, again for this opportunity. Thank you.